they've seen the ENT, and there's not much more that can be done for the patient. It just needs to be monitored and kept on top of, and it's going to remove the skin as often as possible, as and when required. Fortunately, there's no fluid behind the eardrum. We did test that. So the eardrum's fully visible. I am going to put an arrow in a minute so you can see where the eardrum's sucked in. It's just a bit of skin centrally. I just want to see if that peels away. So you may be able to see the rim where the eardrum's sucked in. So it's quite a deep retraction pocket. It's not often you see that part of the eardrum retracted. I said normally it's in the attic, the top part, and you'll see that in the patient's right ear. So I'm now just trying to remove as much skin as possible. Again, we're very deep in the ear. It's going to be very careful that we don't make contact with the ear canal, because that will be uncomfortable for the patient. The patient will need to attend again I think it's been 5 months, so it's almost 2 or 3 times a year they have to attend. Again, it's not possible for us to remove every little aspect. Not only is it not possible, it's not also practical, is that patients having to, as I said, they are quite an elderly patient, and they're sat in an awkward position in their wheelchair. And myself as well, I'm in an awkward position, so I've got to bear probably less than my comfort, but the patient's comfort as well. So we're trying to remove as much as we can, efficiently as possible, so it's comfortable for the patient. And we still got the right ear to do as well. The right ear, there wasn't as much debris, but it was a bit more challenging, the right, because if you think this lateral part of the ear canal is narrow, the right one's even more narrower. Once you get past the outer third of the ear canal, the bony part where we are now, it's a lot wider. It's become more of a normal sized ear canal. It's just the outer third that's very narrow. And it's very likely that the canal has collapsed as we get older again. The cartilage of the ear canal weakens, a bit like the tip of our nose. The cartilage weakens. So the nose, the bottom 2/3 of the nose is made up of cartilage. The upper third of the nose is made up of bone. The ear canal is slightly different. It's only the outer third that's made up of cartilage, and the inner 2/3 is made up of bone. And gravity over the years will take its effect. Cartilage is not as strong as, it's not as rigid as bone. Eventually it will weaken, and it will gravity can take hold of it, and the cartilage can collapse. The cartilage in the ear, the posterior part of the cartilage, can also continue to grow, and it can extend outwards. And when it extends outwards, it hasn't got enough support, so that can also cause it to collapse. So sometimes there is surgery where you can trim that cartilage and almost strengthen that scaffolding. We call that canaloplasty or myotoplasty. And I think we're more or less done. I just want to make sure there's no canal cholesteatoma. Sometimes you can get a formation of dead skin that it can get trapped in some of the ulcerations of the ear canal, the base. You can see there's lots of dead skin there. It can cause a crater or pothole, and skin can fall into that. And again, similarly to a traditional cholesteatoma, a canal cholesteatoma is far more rare. A cholesteatoma in itself is quite rare. It's not something you see every day. But a canal cholesteatoma is even far more rarer, and that can then infect the bone. It can start eroding the bone, the floor of the ear canal, and that infection, once more, it can spread all around the ear to temporal bone. It can affect the jaw. It can affect the mastoid process, which is the bone behind our ear. It can go upwards towards the brain, and it can also